This program is brought to you by Emory University.
Good morning, everyone, and welcome to our Senior Journal Club Fellows Conference Friday. We have two of our senior fellows, Matt Brown and Billy Joe Mullinax, who will be presenting on two separate journal articles. Matt J. Brown is going to go first. Billy Joe will go second, and we'll do questions at the end. So save up your questions for us. All right, guys, take it away.
Okay, thank you for coming. So this is hot off the press. So we're going to be talking about the Fine Arts heart failure trial. I have no disclosures. So I'm just going to kind of take you back in the history of MRAs. So in the hunt for an antihypertensive medication, they noticed a long time ago that progesterone has this natriuretic effect. And so they thought, well, what if we can use that and mold it in a way to get blood pressure control? And so that's how they developed spironolactone. If you kind of rotate it, you see the progesterone body within there. So that was in 1957. But unfortunately, as you know, because of its base molecule, it has a lot of off-target effects, including gynecomastia, dysmenorrhea, erectile dysfunction, because of all the steroidal binding motifs that it can also kind of affect. So jump to 30 years later, it's like, well, what if we can get rid of that? So then they made a small change, and that's how we got eplerenone. Unfortunately, eplerenone, because of that small change, isn't quite as potent as spironolactone, but it does have significantly less steroidal side effects than aldactone. So jump forward to 2021, and they decided, well, how can we develop a medication that's as potent as spironolactone, but doesn't have the side effects, has the side effect profile more like eplerenone or less. And so that led them to develop FINEARTS. So, hold 1 second. Okay. So what is finerenone? So it is a non-steroidal, because it doesn't have that base steroidal portion to it, selective antagonist mineralocorticoid receptor, and it is highly potent and highly selective, as I already said. Here's kind of a breakdown of the structure and just to kind of compare them. So as you can see, they achieved it to be highly potent. For the mineralocorticoid receptor, it's highly selective, and it has kind of less effects on blood pressure than the other two, which is just kind of notable. Okay, so in order to kind of proof of concept of their new medication, they first went into this ARTS trial, and this was a trial where they compared, they call it this BAY948862. The marketing department hadn't come up with finerenone yet, but that's the medication, and they compared it against placebo and aldactone at the time, and also trying to figure out what is the best dose that they can give people. So this is a phase 2 study, and as you notice on the left, it did have some changes in potassium, but not as much as spironolactone. It did improve the kidney function to some degree, but not as much as spironolactone. And it did decrease the blood pressure, but not as much as spironolactone. And this population of patients was heart failure, but not severe heart failure. So they were just getting their feet wet. Then they, and to get a patient population that had a little bit more disease. So this is worsening heart failure. This included patients with diabetes. And again, the last patient population also had CKD. So this also has CKD, but these people are a little bit more disease. So this was, though, against eplerenone. As you can see, it has a much more greater effect on their primary outcome, which is cardiovascular morbidity and mortality, including heart failure hospitalizations. So significant difference compared to eplerenone. And then on the right, you can see here that they're kind of looking at the changes in the NT-proBNP levels, and it did cause a decrease similar to eplerenone at the dose that they're looking to do. They're also kind of honing in on this 10 to 20 milligram dose at this point in time. This is the adverse events, just to kind of kind of clue you in, we're just mostly interested in the potassium here. So eplerenone, the box on the left, just kind of blew it up, and on the right is the finerenone dose at 10 to increase to 20 milligrams over the course of the study, and not as much of a potassium rise as eplerenone, so less side effect profile from that standpoint. And then it had no off-target side effects as well. So now they go into this first phase 3 landmark trial, and there's Figaro and Fidelio, and these are trying to see, how does this affect kidney function and heart disease. But this is the first placebo-controlled trial. So everyone had a 4-week run-in of max dose ACE and ARB, because we all know that those are good for patients with diabetic kidney disease. And then they were randomized to finerenone or placebo, again, picking their dose that they recently discovered that would be most effective, and adjusting it for eGFR, but trying to get to that 20 milligram dose. So this is kind of a breakdown of those two studies, and then the bottom is a combination of all that data put together. So the Fidelio one had a patient population with worsening CKD. It was the latter of the two studies, and it showed their primary outcome was primarily focused on the kidneys, and they showed a decreased progression in CKD, which is somewhat interesting, which we'll talk about a little bit later, and some benefit in cardiovascular mortality. If you put all that data together, they say there's a 14% reduction in cardiovascular mortality and a 23% reduction in CKD progression. So now we kind of jump to what just came out September 1st, which is this FINEARTS trial, which is comparing placebo versus finerenone in patients with HFpEF, with the idea that the mineralocorticoid receptor has been shown rather to decrease remodeling and inflammation, and it is highly upregulated in these patients with HFpEF. And so that was the idea a long time ago for the Top Hats trial, which we'll briefly talk about at the end. And so that's why all these investigators are trying these MRAs to get them to work in this patient population. So the study design is as follows. So it's international. They randomized, it was in 654 sites in 37 countries. They randomized 6,000 people, double-blinded, and the sponsor is Bayer. That's who makes this medication. Inclusion criteria: age greater than 40, NIHA class 2 to 4, and EF of greater than 40%, because below 40% is considered HFrEF according to the AHA guidelines. That's why all these HFpEF trials include an EF of greater than 40%. And then you had to have a BNP greater than 100 if you were in sinus, or greater than 300 if you were in some type of arrhythmia. Exclusion criteria, basically CKD5 coming in with a potassium of 5, but it didn't necessarily permanently exclude them. They could be retested at a later date, and if it was lower than 5, then they were included. BMIs greater than 50, pregnant individuals, and the presence of an LVAD. So here's the baseline characteristics. It's a lot. I'll clue you in on just a few notable ones. There wasn't a lot of enrollment of Black patients, which they attribute, which we'll talk about later, actually. Most of the countries were in Eastern Europe. In terms of this potential what we, I think colloquially and as cardiologists consider the HFrEF category as less than 50%. They had about a third of their patients were in the HFrEF category. So the overwhelming majority is still HFpEF. Most were NIHA 2, and then not a lot of people were on SGLT2 inhibitors, which based on prior studies has been shown to have a small but significant benefit in this patient population. So here are the primary outcomes, and they have a combined of heart failure events and death from cardiovascular causes. And basically, this is mostly driven by heart failure events. They're both in their own right. So the cardiovascular causes in and of itself is not statistically significant because the confidence interval crosses 1. But worsening heart failure events was significant. And that ends up giving a number needed to treat of about 17, which isn't small, but it isn't terrible, I suppose. But it was statistically significant. In terms of secondary outcomes, nothing really checked the box here. So the KCCQ questionnaire was not significant in terms of improvement of quality of life. There was no improvement in NIHA classification for these individuals. Nothing is statistically significant in terms of kidney composite outcomes, which is interesting because, again, the first 2 studies I talked about, that was the main point of those trials. But these patients didn't necessarily have as much CKD, so maybe that's a prerequisite for seeing outcomes in that patient population. Not a lot of, and then no benefit in terms of death from any cause. And then this is kind of, this is the only one where it maybe showed a small benefit of, again, this is kind of a heart failure related outcome of, so, not much different than what we already talked about before. So heart failure is driving a lot of this like heart failure events. Subgroup analysis is always kind of a hot take, but again, we're not here to see if anything is statistically significant, but more so to kind of give us a flavor, if anything, we could study moving forward. A couple important ones, maybe a trend towards more improvement for NIHA classes, 3 and 4, even though there wasn't a lot of enrollment in the study for those. And then, not surprisingly, maybe people with a lower EF have more of a benefit from this medication. Next, we have kind of discordant results with benefit and with kidney function. So kind of like the opposite was true, potentially. And then the investigators in blue wanted us to know that the SGLT inhibitor use didn't show any heterogeneity, and that whether you were on it or not, it did not make a big difference on their medication in terms of outcomes. Adverse events, a lot, this does cause potassium elevation. Again, if this was versus spironolactone, I'm sure you would see a lot more of this. There was 14% versus placebo at 7. So there's some increase, but interestingly, there's not a lot in what I would consider the severe category, which is above 6. That was only 3% and only versus 1.4% in placebo. And even though it doesn't have a strong blood pressure effect, it did show an improvement in people's blood pressure. This is an adverse improvement, but to drop of less than 100. So that tells me that it does have some effect, but we already kind of knew that. It's just not quite as robust as other medications. So limitations and perspective. The authors noted these things. There was few Black patient enrollment, which they said was proportional, though, to the population of the regions that this was studied in. The author also notes that this was conducted during the COVID-19 pandemic, but the results were similar with correction for those factors. So something I kind of think is worth discussing is that, this medication for a 30-day cost, according to GoodRx, is $700 for 30 days. This is out of pocket, obviously, but I'm assuming it's going to be hard to be approved. And then the 36-month cost, which is the course of this study, it was over 3 years, is $25,000. So if you just, for fun, multiply that by the number needed to treat for heart failure hospitalizations over the 3 years, that's $430,000 of healthcare costs to prevent, in theory, 1 heart failure hospitalization, assuming that each of those people were only hospitalized once. So there's a lot of assumptions there, but needless to say, it's a lot of money for maybe a little bit of gain at this point in time. The number needed to treat is probably going to also be higher if this was not compared to placebo, and if you did like cheaper steroidal MRA. I think interestingly, that if this was compared against that, I don't know if we would see, quite the same benefit. So I guess if you have a specific patient population that's worried about the steroidal effects, then this is certainly a good class of medications to go to, because beforehand you only had a eplerenone, which still can cause them. So this is the grand conclusion. And in patients with heart failure with mildly reduced or preserved ejection fraction, finerenone resulted in a significantly lower rate of a composite of total worsening heart failure events and death from cardiovascular causes compared to placebo. Now, briefly, why does this show a composite effect outcome compared to the TopCat trial, which was a similar trial, but again, comparing spironolactone? So just kind of scratching that surface briefly. All that, it's probably not much different. So this was the original data, didn't really show anything, except for maybe a small heart failure hospitalization difference, which we showed too. This was originally a number needed to treat a 45. However, after some retooling and taking out of the Russia and Georgia data, for which it did not show that these patients were maybe getting the medications or taking them correctly. If you just include the Americas, then you start to see a significant effect. So then you start to get the recurrent heart failure events of about 30. So it dropped it by number needed to treat of about 15. And all these end up becoming statistically significant to a small degree. I just included the statistically significant one. So very slight benefit in cardiovascular mortality and recurrent heart failure, but still had some hyperkalemia. You can't really compare apples to apples, but there was a higher percentage of spironolactone causing hyperkalemia than the finerenone did, just as a point of interest. So looking forward for finerenone, Bayer's trying to basically use all the other similar studies that we have with aldactone and see how it compares in these patient populations when it comes to heart failure. So there's the REDEFINE study, which is going to be compared to placebo, looking at HFpEF and HFpEF, kind of similar to this one, but a little bit more expanded. Then there's the confirmation, which is going to add on SGLT2. And then the bottom one in finality heart failure will finally look at HFrEF patients. So those are currently in progress. These are my sources, and that's it.
Good morning, everyone. We're going to change gears a little bit. Still talking about medical therapy, but different patient population. This is the EMPACT-MI trials from a few months ago. I think the first publication was in April. There's been a couple of secondary analyses that come out since, which I am going to touch on a little bit. So this is the use of SGLT2 inhibitors, specifically empagliflozin in AMI patients. I don't have any disclosures. Learning objectives today, I want to briefly go through some of the key medical management literature for AMI patients, go through the mechanism of action, and then the theorized mechanism of action for benefit on this med, and then go through the article, and we can do some appraising of that. I think that their clinical question for this patient population, I've been kind of framing these things in my mind now, is to try to figure out exactly what kind of question I'm asking for a particular patient and then go from there. So for this type of patient, I think we can agree we'd like to improve their mortality if we can, improve the need for hospitalization if needed, and then some other cardiovascular outcomes like MACE, if we can do those things as well, and that's used a fair bit. So again, post-AMI management goals, like we said, recurrent AMI, heart failure admissions, progression of heart failure, and mortality is a lot of what the prior studies have looked at. This is a very busy table, but I think it kind of lays out a lot of what we've done. And if you look at it based on time and outcome there, a lot of the big legwork we made happened mostly in the 90s and early 2000s. Now, I did not include statins on this. I did not include DAPT on this. This is really more of the myocardium medications. But as you can see, after about 05, we have a bit of a gap there. And then we really have some softer outcomes, but nothing crazy. And we take a bit of a pause. So with the first several on there, we actually see mortality benefits. We really jump into the bulk of what we're using: ARBs, ACEs, beta blockers for certain patients, MRAs. And then a couple of years ago, we started looking at the SGLT2 inhibitors in these folks. And that first study, that ME22, it's right here, basically just looked at lab values and EF. There wasn't any really clinical outcomes on that. And then a year later, they do a clinical study, but there was actually no benefit at a year. The rates were very low. They blamed it on COVID. And so then we kind of do some more data and we get into this EMPACT-MI. Then more recently, obviously, we have the reduced AMI, which was pretty hot at ACC. So I think we're kind of refining our thought process on medical management in these folks, which is why I think this study is still important. Just to recap, I know most of us don't remember as much about the nephrons here, but the SGLT inhibitors work in the S1 segment of the proximal tubule. It's obviously a sodium glucose cotransporter. And then based on that, we found that there's obviously a natriuresis component, which I think we think about a lot, but there's some other things on here that to me was a little bit more surprising, mainly being this central or sympathetic nervous system reduction. That seems to be at least theorized, driven by a couple things, but one of the things that's published is this hepatic vagus nerve mediated effect, which subsequently leads to a reduction in the cardiac sympathetic nerve activity and an increase in the parasympathetic nerve activity. The part that we're more familiar with is this natriuresis or intravascular volume improvement, but there's also a stated reduction in blood pressure there. It's pretty mild. And then improvement in the myocardial injury supply, which subsequently leads to a reduction in oxygen consumption. Some other things on here: reduction in inflammation, improvement in autophagy and clearance. We have, this is the sodium hydrogen exchanger, improvement in EPO, provascular progenitor cells, and then like we talked about, the energetics. So several things are theorized here. A lot of this is actually in small studies, but these are the theories behind a lot of the benefit that we've been seeing in so many of our other heart failure studies. This particular EMPACT-MI trial, it was an international, double-blind, placebo-controlled, 1-to-1 RCT. It ultimately was, I think 451 sites, 22 countries. It was sponsored by two companies, Boehringer and Eli Lilly. They were involved in some of the statistical analysis, but they wrote in there that their key analyses were then re-verified by independent statistician. Ultimately, they had 17.9 months of overall follow-up, and most of the patients were between 16.1 and 16.2 or 3 months of being on the medication. They did have a lot of really good follow-up. I will say they had, time to being put into the trial. They had a 2-week virtual visit. Then they had a 6-month face-to-face. Then it was kind of Q 6 months virtual visits. And at the very end of the trial, everyone had a telephone follow-up. They had to report serious outcomes, if they had been off the medication for 7 days, or any outcomes of special interest. This med, obviously, ketosis was involved in that. AKIs was involved in that. Admissions for dehydration, things like that. And then the primary endpoint was a composite of both heart failure hospitalization or death from any cause. So that was in the primary study, that's the primary outcome. They included anyone that was an adult over 18, if you had an AMI within 14 days, and that was either STEMI or an NSTEMI. And they were pretty particular. They wanted it to be spontaneous AMI, and they tried to really exclude diagnoses that would have been considered demand type events, but was a plaque rupture primary ACS event. You had to have either a new EF less than 45, less than or equal to 45%, or signs of congestion that were treated. So that could either be symptoms consistent with heart failure, new heart failure, or an elevation in BNP. And then you also had to have one enrichment factor. These enrichment factors were several things. You could have AFib, you could be greater than 65, a known EF that was reduced without congestion, and other things like that. They had like a whole nice list of other enrichment factors. So you had to have congestion or heart failure with a reduced EF, or one of the enrichment factors. They excluded prior diagnosis of congestive heart failure if you were already going to be taking SGLT2 inhibitor. Obviously, if you could not take an SGLT2 inhibitor, if you had an expectancy of your life less than a year, if they were going to do planned CABG in this index hospitalization, if you were pregnant or breastfeeding, and if you had some other cause of the cardiomyopathy and congestion, they specifically list Takotsubo cardiomyopathy on that. These patients, like I said, were actually mostly STEMI. So it had to be ACS STEMI or NSTEMI, but they were mostly STEMI. Predominantly white men who were older in Europe, and then tend to have mostly a moderate to mid-range EF on this. Again, it was event-driven. They said they needed 532 patients with the endpoint for the power to detect 23% lower event risk. They had initially planned for about a little over 3,000, but they had to increase that to 6,500, and it was an intention to treat. What we found was that what they found for the primary endpoint, they did not reach statistical significance, but within the two components of the primary endpoint, they said that for time to first hospitalization, there was a reduction. However, death with any cause did not. So they basically framed most of their paper around a reduction in total hospitalizations for heart failure and a time to first heart failure hospitalization. Couple figures from the study, Kaplan-Meier curves, the first being on the left, the composite for primary outcome, hospitalization or death, no significance. Death from any cause, no significance. But for first hospitalization of heart failure, they found statistical significance with a hazard ratio of 0.77. When they broke this down a little more, we start seeing that, now this is in one of the secondary analysis, pre-specified secondary analysis, that if you break that down, depending on the type of heart failure hospitalization, all of this favors the drug. So all of this has improvement with the SGLT2 inhibitor. Another one, this figure's pretty, but we're going to spend a minute trying to break it down. They now are trying to say, again, these two papers were published within a month of each other. Another secondary pre-specified secondary analysis that if you looked at, regardless of EF tertile, they kind of broke it into 3 tertiles, or signs of congestion or not, that for the p-value of trend test, all of this had improvement with the medication. So what they found, they broke it into on the far left of that bottom figure, you see EF 35 to 45, so moderate reduction to mid-range EF. Then there's a mid-range to preserved EF, and those are both, that's without congestion, and then it's the mid-range to preserved, and then with congestion, without, with. So they're trying to break it in to say that these different peoples have different types of risk. With this, only 2 of those things actually didn't cross the center line for the confidence interval, and that's the overall time to first hospitalization for heart failure, and then those who have a reduced EF actually without congestion. So this category and then the overall. However, for the trend overall, they're saying that regardless of EF tertile, regardless of congestion or not, they have an improvement in time to first heart failure hospitalization. that they believe the risk is higher if you have a lower EF with congestion, which again, I think makes sense. In the supplemental information, which I don't include on here too, it's actually pretty interesting that there was a signal for if you were going to be sent home on a, what are they listed as like a strong loop or and the SGLT2 inhibitor, they had a signal there for improvement in time to first heart failure hospitalization as well. They don't really go into that, but perhaps that has something to do with synergy between the two and improvement in the congestion. I wanted to just show this because I think that this was, again, it speaks some to this. Yes, there's improvement in the time to first heart failure hospitalization or cardiovascular hospitalization, but number needed to treat on that was still 93. Which brings me to some of my conclusions for their conclusions for this paper. No signal for the primary endpoint, but there was a signal for reduced first hospitalization for heart failure, regardless of EF, but driven by congestion in lower EF patients. My thoughts on it are that, you know, I think if you had a patient who has no contraindication to an SGLT2 inhibitor with congestion and LV systolic dysfunction with or without, then maybe, but it's not really anything that I'm reaching for first. I'm still going to lean on my ACEs and ARBs and plus or minus a beta blocker, depending on their EF, obviously with the new study out. So I don't know that this changes my practice a whole lot. And I'm not super convinced right now that if they don't have an otherwise indication for an SGLT2 inhibitor and it's just the post-AMI, then I'm going to reach for it at all. But I'm open to hear anyone else's thoughts on the matter and would love to answer any questions about that.
Thanks, Billy, Joe, and Matt. That was great. I really appreciate both of your presentations. A couple of comments and questions from the chat. Dr. Ogani pointed out that Grady was a site for Redefine HF and also enrolled patients in EMPACT-MI. Dr. Dickert has a question for you, Matt. And this is what he says. Just to put one question in the queue for you, Matt. The elephant in the room with the series of subsequent trials is the absence of direct comparison between finerenone and spironolactone and eplerenone. The reason for this is probably clear, but would love your thoughts on both the reasons and potential solutions to this problem of not getting the trial that we would all like to see. So what do you think?
Yeah, I was reading through that. I think, and this happens a lot when we get new drugs because these companies get nervous that it's not going to show what they want it to show, and then it's not going to be worth the cost that they're charging for these new medications. Because aldactone is extremely cheap. I think it, you know, it's a little bit of like comparing apples to pears, but if you look at the data alone for aldactone's population, like from TopCats, and you look at it alone in its own silo, in this study itself, I mean, it maybe, you know, shows a benefit with less side effects, but the question is like, are those side effects like statistically significant or like meaningful, I guess? And you know, we prescribe a lot of aldactone, but it's dose and time dependent before you start to get these effects, and even more so of a wider dose and time dependence for eplerenone. So I don't think that they want to see those results. I think they're just saying like, hey, listen, if you happen to have this patient population, we are another alternative to therapy, but they never will do that. I think Dr. Abdu, I saw your hand raised before.
Yeah. You know, Matt, I'm glad you presented this paper and this study, and I found it to be how they designed it. And this is my personal take on this, is that the investigators were extremely cautious, and I think they strategized the study very, very, very well. Look at the study and what it's trying to achieve. It would have been easier for them to test finerenone on heart failure with reduced EF. However, in the shadow of TopCat and what happened in TopCat, they wanted to demonstrate the effect of finerenone on HFpEF patients first. Now, in my eyes, people who rotated with me, either on the clinic side or the inpatient side, in my eyes, TopCat was a relatively positive study. And yes, it didn't reach statistical significance. However, I think there is a huge role of MRAs in HFpEF patients. That's why I think they were aiming to try to see if they can get a very significant or highly positive outcome from a study that compares an MRA for HFpEF patients. And I think relatively they achieved that. They showed them the benefit, albeit it wasn't a mortality benefit, it was a composite. But again, it kind of mirrors the results of TopCat after you eliminate the sites that were not, that were having issues. So to answer Neil's question, actually my question was very similar to Neil's question, and my question was going to be, do you think, from what you read so far and reviewed, do you think they will come with a study that will show a head-to-head comparison between spironolactone and finerenone? I can have you answer that, and then I'll tell you what I think.
I think they have to be very specific in what they're looking for, because and the reason for the original design of the drug. It was designed to have similar potency to aldactone with less side effects. And if they want, and I think their best bet is to, start to parse out those finer details of side effects in terms of aldactone and patients on that dose. It's going to have to be a long follow-up trial though, because, for instance, from what I read, you usually don't see it above 100 or 150 doses of aldactone, and when you do have those doses it takes about a year for people to develop the steroidal effects, and at doses of 50 it can take upwards to 2 years, and that's just when they start. So I think, and again, not everybody gets these side effects, it varies. So
it's a rare side effect to start with.
Right. So if they're really trying to kind of get that, they're going to need a large patient population, and they're going to have to do it for like maybe 5 years. And then they also need to prove that it's as effective as the other medications in what we already know aldactone is good for, which I don't think will be hard, because it's a very strong MRA, but I just don't know if the cost is worth it.
Yeah, as any medicine that comes new to the market is going to be highly priced, and we can drag our feet towards that and talk about it for 10 years and why and how and the politics behind it. But I personally don't think that they're going to have a study that they have a direct head-to-head comparison between spironolactone, eplerenone, and the non-steroidal MRA. I don't think that they will do that. I think the push towards this, there may be a patient population that will benefit from this drug, will be the people with chronic kidney disease, because the first trial was done with those CKD and diabetic patients, and therefore probably it's going to have a market there. However, it will be an interesting drug. It will be another third MRA, I think, if patients can afford it, of course. And shout out to Modley and her team. I mean, enrolling these patients in trials, I think, will be very important. And I see Neil had his hand raised. So, Neil, any questions, remarks?
So Steve Fallenberg sort of wrote in the answer to why you can't do this in HFrEF, right? I think it's important to recognize most people would think it would be unethical to do a placebo control in a HFrEF population where that drug's already been shown to be effective. So I think that was sort of the focus of a lot of my question. That's why they chose HFpEF, because TopCat wasn't. You could still randomize folks to placebo. Because TopCat's not universally accepted as a positive trial. The piece that I was trying to get at in terms of just creative solutions, I think is important for everybody to think through. in some ways, the future, it's very difficult to figure out how to test new drugs in contexts where there is an existing drug that works, because you will probably increase your sample size by about 10-fold. So you're looking at a 40,000 person study to be able to do. The only way we ever are going to get to a spot where we can do those sort of things is when we get payer involvement and health system involvement, and we have sort of relatively pragmatic designs that are not funded by industry, right? That's not a cynical statement about industry, but that's just not something they can be expected to do. So I think that was sort of the what I was getting at, is we have to think differently about how we produce knowledge if we're ever going to be able to study those kinds of things, these kind of big comparative effectiveness sort of questions. So great presentation. I really like. I'm really glad you sort of brought in the comparison with TopCat and just sort of thinking about how we test and roll this out in various populations. But thanks.
And Neil, you're right. I mean, I can piggyback on that. The Transform-HF trial, which compared Lasix, or sorry, furosemide and torsemide, was an NIH trial, and you're absolutely right. You know, that's a really good point. Thanks for pointing it out.
To answer Mariana's question on there, y'all, she asked about, because there were so many NSTEMI patients, ended up being about 25% of the group in the EMPACT-MI trial. Should they be focused more on that? And in the supplemental information for the primary outcome, both of those groups crossed the center line for the confidence interval by a fair bit. However, in the time to first heart failure hospitalization, the NSTEMI group was very close to being statistically significant. So I think that's a very reasonable thought, considering that so many of our NSTEMI patients have a whole lot more comorbidities, more commonly have a lot of comorbidities, that perhaps that group would have more of a benefit. Again, that would be for the heart failure hospitalizations outcome. I don't have anything to suggest that it would be for the primary outcome of mortality or death.
Dr. Ogany, I think I saw your hand up next.
Yeah, great discussion. I think even to add to the complexity of MRAs, I think that there's still more to come on this non-steroidal MRAs. We're about to start, and I think I agree with Mahmoud's points about the beneficial effect in patients who really have impaired kidney function. So we're about to start another trial at Grady that combines both a non-steroidal MRA and dapagliflozin, and we're going to compare like the effects of that combination to dapagliflozin on the risk of heart failure events as well as cardiovascular mortality in patients with heart failure and impaired kidney function across all spectrums of EF. So the EF doesn't kind of matter. So I think we'll have like more information. It's also going to be kind of started as inpatient as well as some patients enrolled as outpatient. So when patients are stabilized for the heart failure management, as well as in that critical early follow-up, patients can be enrolled in this trial. So I think that, heart failure is one field where we have so many medications. I sometimes worry about our patients, like they keep on adding all these medications to the guidelines, and all of that. And how many of this can you get your patients on? Each study says there's a benefit. You're limited by blood pressure. We have to talk about the issue of cost, and I think to Neil's point about pragmatic trials, I think that a lot of discussion is going towards that, as well as, the FDA has a diversity plan, so most of these trials, like for example, the FINEARTS-HF trial you presented, there was no like diverse representation. And even in EMPACT-MI, if you look at typical trials, just like the diversity in those clinical trials. So I think there's a first step, towards like reporting and ensuring and holding sponsors accountable, to make sure like the patients who are really affected by these diseases are enrolled, and I think that also for us as like site investigators, I think that we now have a seat, at the table. I think that at our site at Grady, because we've proven that we can enroll trials, now we have a seat at the table where we're telling sponsors that, you have to address, cover these things, things that make it impossible for patients to enroll in clinical trials, as well as as faculty, we're not just a site enroller. We want to be involved in the academic, pursuits that result from this trial. So I think it's an exciting time for cardiovascular clinical trials, as well as increasing diversity in clinical trials, both as an investigator and as well as patients who are enrolled in these trials. Thanks.
Thank you. Dr. Rob?
So for Billy Joe, to all this, what do you think impact flows in? Is it really ready for prime time or not? Because as you notice, the Europeans have combined both the care of ACS patients to include both STEMI and non-STEMI. And I do think that patients with more preserved LVEF after an infarct, either due to rapid presentation and revascularization, may not need a lot of these drugs. Okay, so I think it'll have to be tailored to the patient itself rather than adding 6 drugs, which are mandated by guideline-directed medical therapy. So where do you think this drug fits in? You clearly don't want to add yet another drug, unless it's really indicated. And I don't think the strength right now is enough to give a strong recommendation.
No, I agree. That's what I was trying to say in my conclusions part, was that I don't plan on using it for purely AMI people, though I think we're all left with that decision if they do have, if they had an infarct and their EF is significantly reduced. I think a lot of us try to be aggressive on adding medications for guideline-directed medical therapy early and often. At least my strategy right now is most of the time I use an ARB, and then later on, if their EF is still reduced, then I move to an Entresto. But I do that in my clinic too. I try the ARB first, then I go to Entresto. That's just how I've been doing it. But for these folks, I think at the very least, I may be reaching for the SGLT2 inhibitor a little bit later. To be fair, though, if they're not requiring a whole lot of a loop before they go, then maybe I would use that instead of even using a loop at all. That's probably what I would do. But again, that's thinking more about heart failure and less about just purely AMI. And they specifically address the thoughts that if this was someone who's going to have significant recovery in their EF, probably because it's all just stunned myocardium from the insult, and then revascularization, they have improvement, that is possible why they're not seeing the benefit as well. So I completely agree, sir.
All right, thanks, guys. Any other questions or comments? Again, thanks to both our senior fellows for wonderful presentations and a great discussion. We'll see everyone next week.
The preceding program is copyrighted by Emory University.